Okay, so welcome to the third video where we talk about qualitative research within the field of health policy. So let's start by thinking about what we know about how policy decisions are made. At this point in your education, that's probably a pretty complex question. You're thinking about interests and institutions and ideas and path dependency and policy entrepreneurs and windows of opportunity and all kinds of evidence. It's overwhelming. I think all of this, probably we could agree that policy decisions aren't just about evidence, and that there's all kinds of other stuff that plays a role in how problems are framed, how solutions are proposed, chosen, and implemented. And I think that we increasingly recognize the importance of social, cultural, political, and human factors in these decisions. And this is where qualitative research comes in. So these social, human, and cultural factors impact the acceptability of proposed solutions, the transferability of solutions from one context to the next, and the way that people are persuaded about the importance of solutions or the practical implementation factors about solutions. And I think that this is where qualitative research really shines, because it can help identify the interplay between these factors, the contextual issues, and the gaps between what we know and what we need to know. While qualitative evidence can be useful to decision makers, it can also be used to study the process of decision making itself. So there's sort of a dual role here. I think about the role of qualitative research in policy in terms of two different types. One is surfacing the issues that exist, so this is the more descriptive factual type work, and the other is offering some suggestions for what we should do about these issues. So this is the more theoretical, normative work about values. I've put a couple of readings on Avenue. A note about the Murphy and Dingwall one. I did scan the introductory chapter and I'll put that up for you guys, but I think it's a bit dated. They spend a lot of time talking about skepticism about qualitative research in health policy that in my experience is quite different from the skepticism that they discuss. So in this video, I'm going to talk about qualitative research in two different types of policy decisions. The first is health technology assessment, which is very structured, and so there's lots of clear ways in which qualitative research can fit in. There's a variety of accepted methods and increasingly routinized procedures for integrating qualitative research. The second example is a recently completed project that I was involved in, which involved primary empirical case study, and that was commissioned by the College of Family Physicians of Canada. This was a more ad hoc policy responsive project where there wasn't a variety of frameworks and methods to rely on that we had to kind of fit our qualitative methods within. Rather, the college put out a request for proposals, and we responded proposing that we would do a qualitative project to answer their questions. Okay, so first, health technology assessment. Just for those of you who might not be familiar with HTA, give you a definition that comes from the WHO, and that is that health technology assessment refers to the systematic evaluation of properties, effects, and/or impacts of health technology. It's a multidisciplinary process to evaluate the social, economic, organizational, and ethical issues of a health intervention or health technology, and its main purpose is to inform policy decision making. So what can qualitative research contribute to HTA? I think it's very useful for identifying social values, ethical issues. It can contribute patient perspectives, and is particularly useful in contributing information from populations which are hard to reach. There's a bunch of different ways that qualitative research is typically integrated in HTA. It can provide evidence from which to consider ethical issues. Very commonly, folks will review a collection of primary studies and do sort of a synthesis of those, and this is something that I've done quite a bit of. There's increasing interest in involving patients in HTA, and often some of the methods of involving patients look quite a lot like qualitative research. And then every once in a while, an HTA will decide to commission a primary qualitative research study. In terms of the types of information that qualitative research can contribute, it can provide evidence for these social, psychological, ethical, and organizational assessments. It can provide information about the context in which a technology is understood, implemented, and used. And it can also inform some of the value judgments that are necessary as part of HTA, including the scoping of the technology and determination of the appropriate outcomes and metrics. Some of the information that might be useful or might be included in an HTA, especially the type of evidence syntheses of existing qualitative research, can draw on social science research about experiences and understandings of illness and healthcare, can contribute information about preferences for healthcare, about patient-defined aspects of processes or outcomes of care, and about unmet needs that need to be addressed. There's also bodies of empirical and theoretical research that can draw attention to ethical and social issues, which may include perspectives or interests not yet included in an evaluation, the identification of groups that might benefit or be disadvantaged by an intervention, and public opinions about controversial issues. So lots of different ways that qualitative research could contribute to policy decision making here. Okay, the second example is some research that I have been participating in that was commissioned by the College of Family Physicians of Canada, which is a regulatory accreditation national body for family physicians in Canada. And they have a membership of about 30 or 35,000 physicians, so they're quite a large group. This is very recent, so we just submitted the report to them in February, and I was planning to present the findings of that report at a conference in April, which has just been canceled, unfortunately. Okay, so how did this arise? And I'm talking about this example because it's, I think, quite common. So just in terms of how qualitative research or how qualitative researchers get involved in health policy, if it's not that you've done this investigator-driven research that's just out in the world that somebody finds and synthesizes for a policymaker, like in HTA, it often happens like this, where a decision-making group identifies questions that they have, and they might put out a request for proposals. They might contact researchers that they're aware of who work in the area directly and ask them to do some research. So typically they'll give some direction, some questions, and the funding, and then the researcher will conduct the research in partnership, really, with the organization. And so that's certainly what happened here. So the college had some questions about their Certificates of Added Competence program. Now, the Certificates of Added Competence, or CACs, are a means of recognizing enhanced areas of expertise achieved and maintained by some family physicians. And so in April 2018, the CFPC released a request for proposals to help them understand the impact of this program. And in particular, the request for proposals identified a policy question about the future of the CAC program, including a need to understand the desirability of additional CACs. So my team identified the request for proposal, and we developed some objectives and a proposal for methods to answer those objectives. When we were chosen as the successful team, we continued to work with the CFPC to refine the objectives to really make sure that they were in line with the policy questions and the interests that the college had. And so here are the objectives of our proposal. So it was about developing a way to profile the folks who hold CACs, to understand the impact and the influence of the CAC program on a number of things, including the provision and the outcomes of comprehensive community-based care, as well as the impact and the influence on the members of the College of the Family Physicians. As well as to develop an understanding of the influence of this program on trainee decisions and to determine the risks and benefits of introducing more CACs. So what we proposed to do was a mixed methods multiple case study design. So we started with quite a bit of consultation with the college and representatives of the college in various parts of Canada. We then conducted a qualitative case study, first doing an exploratory case study and then doing an explanatory case study, where we examined 6 different cases, which we defined as a practice or a collective of family physicians working in an interconnected community. Finally, we conducted a national survey of family physicians, including those who held CACs and those who don't hold CACs, in order to test and refine some of the propositions that we developed from the qualitative research. So this is sort of a schematic diagram of what our design looked like, and it's not terribly important. It just gives me a chance to talk about the fact that we worked with the college all throughout to make sure that the way that we were developing the project was in line with the type of information that they would find helpful to answer their policy questions. And so we did our exploratory cases. We had 4 different cases here, each with various embedded units. And then we refined our propositions through a cross-case analysis of these exploratory cases. We conducted 2 more explanatory cases, did some cross-case analysis of all 6 at that point, and then we further refined our theoretical propositions in order to develop and conduct the national survey when we finally produced our final report. And then we have ideas for a number of other more scholarly manuscripts that we'll produce afterwards. So our case studies included 6 groups of family physicians that were spread throughout Canada, and I've taken the geographic markers off the map here just to preserve the confidentiality because we're not quite done with this. But they were all different types of arrangements of groups located within cities that had tertiary care and up to 8 hours away from tertiary care. So some of the benefits of using qualitative research to answer this policy question were that it offered some really great context for how the CACs were working in different parts of the country and how different CACs work differently, how CACs in different types of arrangements, so for instance in a more rural community as opposed to an urban community, it really let us dig into some of the important contextual factors. I think the exploratory approach was essential because we didn't really know what mattered. We didn't know what types of impact or what types of influence this program had, and so we really wouldn't have known what to measure if we didn't start out with this exploratory qualitative research. It also allowed different perspectives to come forth. So this is kind of a politicized program, especially in some different areas, and so a qualitative approach allowed a variety of folks to have their say and to make their divergent voices heard. It also allowed us to be attentive to the differences in the way the program operated, whether that was jurisdictional in different provinces or about the type of practice arrangements, the specific type of CACs, whether it was family practice anesthesia or palliative care or whatever it was in, the way that the group related to different parts of the healthcare system and the different populations that they served. So we knew going into this that the CAC program is very diverse, and the case study approach really allowed us to accommodate that diversity in our study. Now, the drawbacks of using qualitative research. Well, for one, there was a lot of specific questions that could have been answered quantitatively that we just didn't propose to answer because they weren't possible to answer qualitatively. So questions about the financial implications or care outcomes or that kind of thing. The generalizability of findings, because this was a qualitative case study, our findings were really about the particular cases, and we were able to, through our cross-case analysis, identify some things that were consistent across our cases, but that's really not really the aim of case study. And there also might be specific questions that arise policy-wise that we didn't measure. So the CFPC might have a particular CAC in mind that they're interested in implementing, but because that wasn't part of our study, we didn't look for that, we didn't ask people about it, we don't have any information to offer on that. In terms of where the work is now, so we submitted our report. We received comments and queries back from the group of college stakeholders that we were working closely with. And we're just working on incorporating those revisions. We're then going to take this report to a couple different committees within the college who are working on various issues related to the CAC program, and we'll continue to be available to work with those committees to answer their questions, to conduct additional analyses as their decision-making process proceeds. And then, of course, we've got lots of rich data to develop scholarly manuscripts from outside of the specific deliverables that were promised for the decision-making body. Sort of a win-win for both groups. In any case, those are 2 examples of qualitative research in health policy that I hope illustrate some of the range of possibilities of this approach in this field.